It's really an honor and a privilege for me to be here and have the opportunity to share with you some of my thoughts on the echocardiographic evaluation of left ventricular diastolic function. I have no relevant financial relationships with which to disclose. Now, when we're talking about the evaluation of left ventricular diastolic function, that's really a bit of a misnomer because we're really assessing left ventricular diastolic filling and the physiologic consequences of abnormal filling, the elevation in filling pressure. And as Simon Sinek would say, we often should start with the question why. And the reason we do this is that if we're looking at patients that have a reduced LV ejection fraction, really there to assess filling pressures. For those that have a preserved LV ejection fraction, we're either trying to diagnose normal, those that may have heart failure with preserved ejection fraction, or perhaps those with a restrictive cardiomyopathy. Now in 2016, the ASC and EACVI came out with their guidelines document for the assessment of LV diastolic function. And as you go through this document, you can see there are a number of 2D and Doppler variables that are listed, and their values can be acquired and integrated for the assessment of LV diastolic function, or really diastolic filling. There are in fact 17 of these variables listed. So echo is really a very powerful tool, a tool that can provide us this key to unlock many of the mysteries of diastole. And although, as we just mentioned, there are a number of different variables that can be acquired. In fact, as the guidelines stated, 17 different variables that can be acquired and their values integrated. What I'd like to share with you is that there are really 4 key variables that we use in daily practice. One is a volume-based measure of LA size, and perhaps in the future a function-based measure of the left atrium, to look at blood flow velocities, in particular the mitral inflow velocity profile, to evaluate LV function, ejection fraction, and annular velocities, and finally the TR velocity. And these 4 variables can be used to shape this key, which can fit this lock. So key measurement number 1 is generally this volume-based measure of left atrial size. And it's key measurement number 1 because for the most part, it gives us insights into the chronicity of elevation in left ventricular filling pressure. So that if you see a dilated left atrium, for the most part, not always, but generally it means that over time, LV filling pressures have been increased. What it doesn't tell us, though, is what are the filling pressures at the instant in time of our evaluation, and for that, we need to look at some of the other key parameters. Key measurement number 2 is the mitral inflow velocity profile, generally characterized by the amplitude of the E wave, the A wave, and the E wave deceleration time, as listed here. And we see that the deceleration time is sort of grayed out because less emphasis is placed on this in the current guidelines. Now, as an aside, when you see a mitral inflow velocity profile like this, which has a nonlinear decay in the E wave velocity, should we be measuring this initial slope in green, or should we measure this second slope in red? The answer is that when assessing for LV filling pressures, we want to measure this initial slope in green. And this may be distinctly opposite from what we're told to do in the assessment, say, of pressure halftime for those with mitral stenosis. So with a nonlinear decay in E wave velocity, we want to measure this initial slope in green. Key measurement number 3 is an evaluation of LV function. We first look at LV ejection fraction. Is the EF normal, defined as greater than or equal to 50%, or abnormal or reduced, less than 50%? Then, in particular, in patients that have a normal LV ejection fraction, we look at the annular velocities, or this E prime velocity, because the E prime velocity is a good indicator of myocardial relaxation, and LV myocardial relaxation is an important component of diastolic function. So key measurement number 4 is a measure of the tricuspid regurgitation velocity, because there's a significant correlation which exists between the systolic PA pressure and non-invasively derived left atrial pressure. So in the absence of pulmonary disease, an increased systolic PA pressure suggests an elevated left atrial pressure. So to cut to the chase, in routine daily practice, there are these 4 key parameters that we look at in the evaluation for LV diastolic function. There is the chronicity parameter of the left atrial indexed volume and the acuity parameters, helping us to determine the filling pressures at the instant in time of our evaluation. Looking at mitral inflow velocity profiles, measures of ventricular function such as ejection fraction and or annular velocities, and finally the TR velocity. So now let's take a look at the natural history of diastolic function, or really LV filling. And what you can appreciate when looking at the cartoons of the mitral inflow velocity profile on the bottom is that it reflects the combined influence of delayed relaxation, this grade 1 pattern, and as we move to the right, delayed relaxation with associated increase in filling pressure. And you also see the arrows going in both directions, showing this concept of ventriculovascular coupling, such that as we change the hemodynamic milieu, we may be able to change the morphology of the mitral inflow velocity profile. So if you have a grade 1 pattern and you increase afterload by, say, an increase in blood pressure, or you increase the preload by a leg lift, you may be able to change the delayed relaxation pattern to more of a normal looking pattern. Similarly, if you have elevation in filling pressure, say a restrictive filling pattern or a grade 2 pattern, and you decrease preload, say during the strain phase of the Valsalva maneuver, you may see a morphologic change in the mitral inflow velocity profile to grade 1. This concept again of ventriculovascular coupling. Now clinically we see this, what may be determined grade 3B, where you have a restrictive filling pattern, but you can see here the arrow only points in one direction. So changes in the hemodynamic milieu cannot change the morphology of this inflow velocity profile. So there isn't really this ventricular vascular coupling. These people truly have a restrictive cardiomyopathy, a fibrotic and scarred and non-compliant left ventricle. So as we're looking to evaluate diastolic function or filling pressures in those that have a low LV ejection fraction, it's first important to recognize is that they really can't be normal, because what happened in systole influences diastole. So if you have abnormal systolic function, you will have abnormal diastolic function. So here when we look at the mitral inflow velocity profile, if they have this grade 1 pattern, we know that they're compensated and they have low normal filling pressures. The others are decompensated and have increased left ventricular filling pressures. All of these patients may receive beta blockers, ACE inhibitors, ARBs or ARNIs, aldosterone receptor antagonists, SGLT2 inhibitors, but it's those patients that are decompensated that may also receive diuretics to help to support symptoms. So as we're evaluating diastolic function, or again filling pressures in those that have a low LV ejection fraction, we know that they're not normal. They either have abnormal relaxation or abnormal relaxation with associated elevation in filling pressure. So the grade 1 patients have a low EA ratio, less than or equal to zero 0.8, and a low E wave velocity, less than or equal to 50 centimeters per second. And that makes sense because if the left atrial pressure is low, then as mitral valve opens, blood's just not being jammed into the LV at a high velocity. However, as we move to the far right, and now the EA ratio is greater than or equal to 2, these patients would have grade 3 diastolic dysfunction. Now in the middle, there can be these shades of gray. Now, as we're living within the shades of gray, that means we need to do something else to help crystallize our thoughts. And here's where the guidelines can be very helpful. And when I look at the guidelines, I often think of this concept of the rule of twos. Let me explain this to you. Now, the guidelines give us a number of different algorithms with which to use, again, to help standardize the reporting of patients' diastolic function or elevation and filling pressures. And one of these algorithms looks at those that have a depressed LV ejection fraction or a normal LV ejection fraction in myocardial disease. And the question is, how do you define myocardial disease? Is it because the patient had a myocardial infarction or the presence of hypertension or the fact that they have hypertrophic cardiomyopathy? And let me just simplify this for you. And this is a change really in the way I look at the guidelines. And the fact is that we define myocardial disease not by a historical perspective of a clinical condition, but simply by the presence of a reduced E prime velocity. A medial annular velocity less than 7 or a lateral annular velocity of less than 10 centimeters per second. And as we said, if the EA ratio is low, these patients would have normal left atrial pressure. If in this scenario, the EA ratio is greater than or equal to 2, this would be grade 3 diastolic dysfunction. But if they were somewhere in the middle, EA less than or equal to 0.8, but the E wave velocity is more than 50 centimeters per second, or the EA ratio is between 0.8 and 2, then we need to look at these other key indices. The E over E prime ratio, the TR velocity, the left atrial pressure, and follow the rule of twos. 2 or more are normal, we would say grade 1 pattern. 2 or more abnormal, we would say grade 2 or increase in filling pressure. So let's look at this 59-year-old male with renal failure who has a low left ventricular ejection fraction. So if we had the mitral inflow velocity profile on the top with a low E wave velocity less than 50 centimeters per second and an EA ratio less than 0.8, this patient would have grade 1 diastolic dysfunction, no other parameters are required, and we know there's compensated or low normal filling pressure. On the bottom, in this patient with a low ejection fraction and an EA ratio greater than 2, we would say this patient has grade 3 diastolic dysfunction, no other parameters are required, and this patient would be decompensated with increased filling pressure. But if we had the mitral inflow velocity profile in the middle, a low EA ratio, but the E wave velocity is greater than 70 centimeters per second, the EA ratio is greater than 0.8, we're not sure. And now we have to look at some of these other parameters and follow, as we say, the rule of twos. So here we can calculate the E over E prime ratio. We can take the E wave velocity, 70 centimeters per second, divided by the medial annular here E prime velocity of 4 centimeters per second, this giving us a value of 17.5. And you see, the way this works is this. Here we see the LV pressure and the left atrial pressure. On the bottom, we see the mitral inflow velocity profile and the E prime velocity. And as we play this animation and we see that as the LV begins to relax more slowly, not only does the E wave velocity decrease, but the E prime velocity decreases. Now, as left atrial pressure increases, right, blood gets forced into the LV at a higher velocity, the mitral inflow E wave velocity increases, but the parameter of LV relaxation doesn't change. It's not changing the function of the LV. It's just that the filling pressures increase, so the E prime velocity stays low. As the LA pressure increases even more, now blood gets jammed into the LV at a higher velocity, increases the E wave velocity, but the parameter of LV relaxation does not change and the E prime velocity stays low. And this is why we can correct the amplitude of the E wave with the amplitude of the E prime to give us this E over E prime ratio. And the guidelines tell us that if we average the E prime using both the medial and lateral annular values, a number greater than 14 is a dichotomous cut point for normal or abnormal. Single site medial and lateral E prime velocities and E over E prime ratios as noted here. So we did suffice at least one of the other parameters, an E over E prime ratio greater than, here using medial, greater than 15. So we need another parameter, and here we're looking at the TR velocity. And although we may not have the greatest TR velocity envelope, we certainly know that the amplitude is greater than the 2.8 that the guidelines suggest. So now two or more of these additional parameters are abnormal. This suffices the rule of twos, and this patient would have grade 2 diastolic dysfunction. Now, what about this 34-year-old male who has stage 1 hypertension, and you see here normal left ventricular ejection fraction? If we look at the mitral inflow velocity profile, we see an EA ratio that's high. It's greater than 2. It's in fact 2.4. And if we go back to this diagram of evaluating diastolic function or LV filling pressure, you would see that, wait a minute, if they have an EA ratio of greater than 2, this must be grade 3 diastolic dysfunction. In these patients, however, it's very important to look at the annular velocities. On the right, we see a very robust E prime velocity of 20 centimeters per second. This means the patient's ventricle is relaxing very quickly and literally sucking blood in at a higher velocity. A low E over E prime ratio. This is a good profile. On the bottom, we see a low E prime velocity and a high E over E prime ratio. This means that the high E wave velocity is being generated not because the left ventricle is relaxing more quickly and literally sucking blood in at a higher velocity, but because the left atrial pressure is high. And now when the mitral valve opens, blood is being jammed into the LV at a higher velocity. So when we see patients that have a normal LV ejection fraction and a high EA ratio, this does not necessarily always mean restriction. That individual can have sort of supernormal LV filling. And we can differentiate these patients by looking at the annular velocities. A high E prime velocity and a low E over E prime ratio would be supernormal. Patients that have a low E prime velocity and a high E over E prime ratio, this would be restricted filling. Similarly, the profiles in blue, which look somewhat normal, can differentiate normal from pseudonormal by looking again at annular velocities. Normal annular velocity. So if we return to this graphic, we see that patients that have grade 1 diastolic dysfunction or abnormal relaxation, the mitral inflow velocity profile shows a low EA ratio. And as we move to the right, the mitral inflow velocity profile again represents the combined influence of not just delayed LV relaxation, but delayed LV relaxation with associated elevation in filling pressure. And the patients to the right have abnormal ventricular function. If not noted by a reduction in LV ejection fraction, it is noted by a reduction in the annular velocity or E prime velocity. Now, what then if we had a patient like this who had a big EA ratio and a high E wave velocity? On the right, a pretty good E prime velocity, but the E over E prime ratio is 10. And here we're using the lateral annular E prime velocity. This value is less than 13, but it's also greater than 8. So they're sitting in the middle. Now what do we do? Well, we can go back to the guidelines and look at the algorithms to look at patients that have a normal EF. And they suggest looking at these various parameters, and then we can follow the rule of twos. So if less than 50% are positive, they may have normal diastolic function, or I'd say normal filling pressure. If more than 50% are positive, they'd say abnormal diastolic function, or I'd say increase in LV filling pressure. And if 50% or so are positive, they say indeterminate. And then we'd have to look at obviously some other factors. But wait a minute. I said a few moments ago that in order to use the algorithm of patients that have a normal EF and myocardial disease, we defined myocardial disease by the presence of a low annular velocity, right? In E prime velocity less than 7 or a lateral E prime velocity less than 10. So obviously then we can't use this in this particular algorithm. And this is where I would differ a little bit from the guidelines. So I'd say in order to use this algorithm, we need to have a normal EF and a normal E prime velocity. So So if we're going to assess diastolic function in patients with not just a normal left ventricular ejection fraction, but those with a normal LV ejection fraction and E prime velocity, then we can look at the parameters in black listed below, of course, eliminating the annular velocities. And I'd say that if none of those three parameters, 1, 3, or 4 are positive, then we'd say normal filling pressure. If 2 or more of those three parameters are positive, we'd say increased filling pressures. But if just one of them's positive, then we're stuck. And to follow the rule of twos, we're going to have to add something else. And what may be those additional parameters? So one thing we can do is transiently change the hemodynamic milieu and see if we can change the phenotype of the mitral inflow velocity profile. So in this example on the left, where we have a somewhat normal looking mitral inflow velocity profile, if during the strain phase of the Valsalva maneuver, we're able to decrease that EA ratio by at least 50% or see an increase in the A wave velocity not associated with fusion of the EA, This can be highly specific for an increase in LV filling pressure. The problem with this maneuver is not every patient can perform it adequately. So the patient needs to generate and sustain a sufficient increase in intrathoracic pressure. The guidelines suggest generating at least 40 millimeters of mercury of intrathoracic pressure and sustain this for about 10 seconds. Additionally, the imager needs to maintain the correct sample volume location between the mitral leaflet tips during this maneuver. So it can be difficult not only to assess, but also to standardize this maneuver, but is helpful at times in assessment of LV filling pressure. Another thing we can look at is information gleaned from the pulmonary venous flow profile. Here from the apical four-chamber view, we see color from the right upper pulmonary vein. We can place a pulse wave sample volume about 1 to 2 centimeters into this right upper pulmonary vein using a 2 to 3 millimeter gauge size. So here we see the pulmonary vein velocity profile, generally characterized by a systolic and diastolic filling wave and an A wave reversal. And really to optimize this signal, we have the patient suspend respiration and end expiration. And it's important as well to ensure that we have the wall filter settings set low enough so that we can display both the onset and the termination of the atrial reversal velocity. So what we know is that as the systolic filling fraction decreases, so the S wave becomes less than the D wave, it's been reported a value less than about 40% or so is related to a decrease in LA compliance and an increase in mean left atrial pressure or pulmonary capillary wedge pressure. However, this has limited accuracy in patients that either have a normal LV ejection fraction or significant mitral regurgitation. And we've been talking about adding parameters specifically to those patients that have a normal LV ejection fraction. So although the systolic filling fraction may have a limited value in those that have a normal LV ejection fraction, what we can look at is the relationship of the duration of the mitral A wave to the pulmonary venous A wave reversal. Meaning that as the left atrium contracts, yes, blood flows forward through the mitral valve into the left ventricle, but there are no valves on the pulmonary veins, so blood also flows back through the pulmonary veins. If LV compliance is poor, as the atria contract, the forward flow through the mitral valve stops before the flow stops going back through the pulmonary veins. And it has been suggested that if you look at the relationship to the pulmonary venous A wave reversal to the mitral A wave duration, that a value greater than about 30 milliseconds would suggest an increase in left ventricular end diastolic pressure. This is a post A wave pressure or end diastolic pressure. So a technical tip might be that instead of placing the pulse wave sample volume here at the mitral leaflet tips, as we would need to when measuring the amplitude of the E wave and the A wave in the assessment of LV filling pressures. But now we move the pulse wave sample volume closer to the annulus. And we set the wall filters low enough so that we can discretely see now the onset and termination of flow following atrial contraction. So if we look at the mitral A wave duration and the pulmonary venous A wave reversal duration, we could then take this 200 milliseconds. From this, we could subtract the A wave duration here of 160 milliseconds, giving us a value of 40 milliseconds. And as we said, a value greater than about 30 milliseconds indicates an increase in LV end diastolic pressure, and this is independent of left ventricular ejection fraction. So, as we are working to assess diastolic function in patients with not just a normal left ventricular ejection fraction, but a normal EF and a normal E prime velocity, then in the algorithm, we have to add something else. And that something else, as we've just discussed, is the response of the mitral inflow velocity profile to the strain phase of the Valsalva maneuver and the duration of the pulmonary venous A wave to the mitral A wave. And when doing this, we can then again follow the rule of twos. Two or more are positive. This is an increase in filling pressure. Less than two are positive. We'd say normal filling pressure. So I left you with these four key measurements that we really use in daily practice. A chronicity index, the volume-based measure of left atrial size, and then acuity indices, the filling pressures at the instant in time by looking at the mitral inflow velocity profiles, LVEF, TR velocity, and here's some dichotomous cut points for quick reference. Now, I've also been asked to make some comments on the impact of aging on diastolic function. And presumably, there is also slowing of myocardial relaxation as we age, and this can account for the frequent finding of a decrease in the mitral EA ratio or a more delayed relaxation pattern and the finding of a low E prime velocity. But it's important to note that although this is common, it is not normal. So, for example, in the elderly, it may be more common to identify osteoarthritis of the joints, but that's not normal. In the elderly, as echocardiographers, we may identify the more presence of aortic sclerosis, but that's not normal and is associated with adverse prognosis. Similarly, the finding of a delayed E prime velocity or a reduction in EA ratio is common in the elderly, but not necessarily normal. However, when asked to evaluate for LV filling pressures, there are indices which are less age dependent. The E over E prime ratio, the changes in the mitral inflow velocity profile during the strain phase of the Valsalva maneuver, and the duration between the pulmonary venous A wave reversal velocity and the mitral A wave velocity. These parameters still remain normal in the elderly and can be used for the assessment of LV filling pressure independent of age. Now, we've assessed the evaluation of left ventricular diastolic filling in those with normal or abnormal left ventricular function. But there are some other special circumstances we should be aware of, like what do we do in patients that have mitral annular calcification or mitral stenosis? What about those that have atrial fibrillation or flutter or the presence of hypertrophic cardiomyopathy, plus or minus the presence of systolic anterior motion of the mitral valve and associated significant mitral regurgitation? Our discussion is focused really in those in the resting state. What about concepts of diastolic function abnormalities during exercise and comments of diastolic stress testing? And I think before the examination, it may be worth going back to the guidelines document and reviewing some of these special circumstances now with a broader understanding as we've discussed today. We should also be aware of some emerging parameters, not just looking, for example, at volume measures of the left atrium, but also at left atrial function, particularly left atrial strain. And this was discussed briefly in the strain lecture. So we've looked at the echocardiographic evaluation of left ventricular diastolic function, or really more specifically, the physiologic consequences of abnormal diastolic function or diastolic filling, that is the elevation in filling pressure. And on the surface, it's really quite simplistic. Are filling pressures normal or abnormal? But you realize as you get into this, there can be great complexity. And in fact, the guidelines give us 17 different variables. Those values can be acquired and integrated in the assessment of LV filling pressure. And I've hoped to sift through some of this for you and to create some elegant simplicities in our assessment. I thank you very much for your time and attention, and for those going on to take the examination, I wish you all the very best of luck.